Vilsa is with us today. Vilsa is our clinical director here at Aspen Grove Behavioral Hospital. And she received her MS and PhD degrees from Brigham Young University. She has extensive experience working with children, as well as adolescents, young adults, couples, and families. And her main clinical specialty is treating children who have been in traumatic experiences. She's going to talk to us today a little bit about suicide risk and the ethical considerations in the assessment and management of suicidal clients. So without further ado, I will turn the time over to Vilsa.
Thank you, Joseph, and welcome everybody. Let's have some fun this hour. As we are going to go through this presentation, I'd like you to also be a little bit more interactive with me. There will be some in some of our slides, I would like to ask you guys some questions, and if you have experiences with this particular topic, which most of you, almost all of you, have had those kind of experiences. So let's talk a little bit about what has worked for you, what success stories you have had, and what have you found as best practices to work with suicidal patients. I work at a hospital, so I'm used to the word patients, but please personalize it to the setting that you are working. It can be a client or it can be a patient. But since I'm working at a hospital, we are so used to working with patients. Our suicidal ideation among our population has increased, especially working at Aspen Grove Behavioral Hospital. One of the main things that we see in here is an increased suicidal ideation and increased attempts actually in any type of population. It can be women, it can be adolescents, it can be adult, it can be chemical dependency. So this is an issue that is really getting our attention. I looked at some statistics and I thought might be interesting for you as well to see how are we doing in this area. The latest statistics that are available are from 2022, and it seems like this has been a very difficult month for a lot of people. It has been, I did some research about why was 2022 more difficult than others. Not necessarily any more difficult than 2020 or 2021 as the population was struggling with COVID. But in 2022, we had a peak in deaths by suicide. We lost 49,000 lives, and it is quite a bit. One life in every 11 minutes. That's actually quite a bit for a population. That means that mental health is not necessarily an area that we are providing a lot of services or we are reaching a lot of people, and most likely we need to do more. To have one death every 11 minutes, it is a lot of deaths. So we've got to do something about helping our suicidal patients and helping our population in general. Just some more stats for you guys you can see in this particular slide. And let me know if any of you has any problems seeing the slides, you guys. I think I'm sharing, but let me know. Look at the rates that are increasing from 2006 to 2018 is just straight line going up. And then we get a drop in 2020, and then we reached the peak in 2022. Financial difficulties, coping with COVID. A lot of people were out of work, so really a very difficult year for a lot of us. And if you see by ethnicity, by race or ethnicity, this was actually a surprise to me. I did not think that this population, the Native Americans and Alaska Natives, would have the highest rates of suicide in 2022, but they make up 27. You can see the highest number in this particular population. And when it comes to gender, males are more likely to die by suicide than females. But also look at the age. This slide also, or this information in this slide also surprised me. I thought that I honestly thought that the highest population who would be more likely, or the population who would be more likely to die by suicide would be probably 35 to 45 till 50 years old. And I was wrong. It is actually 85 plus in 2022 alone. That is surprising. To me, that means or to me, it raises a question. Are we really taking care of our elderly? And what are their challenges? So that is something to consider for you guys who are working with geriatric populations. You might have some insight about why in 2022, the 85 plus year old died more often by suicide than any other age. So I'm not quite sure if any of you would like to share something in the chat and see if you are working with this particular with geriatrics. What were some of the challenges that they noted or that you noticed in this particular population? Anybody works with geriatrics? Okay. All right. Isolation, absolutely. Lack of family support. Yes. Elderly client, oh, affordability of care, finances, absolutely, you guys. These are health issues. Yes. Medical complexities. Excellent feedback. Feeling like a burden. Wow. Chronic illness. Yes. That is transportation. Absolutely. This is great. I appreciate all of this feedback. That's something that we need to take care of. Maybe pay a little bit more attention to this population, because that means if they were higher risk in 2022, that means they're going to be, they will continue to be a high risk population. Pain and lack of independence. Absolutely. Yes. Excellent feedback in this one. Thank you so much, you guys. Let's see. Let's move on. What do we have now? Well, I'm frozen. Okay. Here is by methods. Firearms, the most common one. And then after that is suffocation. Easy things that you could, especially the suffocation, you don't even have to buy a gun. It can be something at home. A pillow can do it. A plastic bag can do it. So these are things that are very easy, or this method is very easy to be implemented. So we really need to increase awareness, and really need to make sure that our therapists, our newer therapists, understand how to assess suicidal ideation, how to detect the red flags, so we can actually take care of our people. A lot of things goes into taking care of clients with suicidal ideation. Today, I'd like to talk a little bit about the ethics of working with suicidal patients. And there were a couple of questions in the chat. How are we going to count this presentation? Is this ethics or is it suicide? We can probably split this half and half. So maybe it's 0.5 for ethics and 0.5 for suicide, so you guys can get the best of both worlds. How many of you actually have seen those ethical principles? These are not new. I did not come up with those. This is coming from research. But how many of you have seen those before, and you say, "Oh yeah, I always kept those in mind. I'm very familiar with this ethical principles, and I totally apply them when I work with suicidal clients." Okay, no, I don't see any responses. That doesn't mean that you have not heard them. Maybe some of you have not heard them, and that's okay. That's why we're going to review them today. Okay, some of those ethical principles: respect for person. We've got to protect their dignity and their individual's worth. When a client comes to us as therapists struggling with suicidal ideation, It is difficult for them. It is difficult for us as well, but it is difficult for them to be at that vulnerable place and to be able to let another person know that they are feeling suicidal. So as we work with them, we're going to review those principles again, but as we work with them, we need to understand that we need to protect their dignity and their individual worth. They are individuals who are struggling. They can be your next door neighbor. They can be your uncle. They can be somebody that you know. It doesn't matter who they are. Everybody has their own dignity. Everybody has their own worth, and we need to make sure that we protect and we respect that dignity. Autonomy, respect for clients' right, and self-governance. A lot of times I've worked with individuals who have not wanted to be receiving treatment in a hospital. They don't want to. Sometimes I've known people who have not even wanted to actually address the suicidal feelings. They simply wanted to die. This is, I think we need to talk a little bit more about this. Basically, how do we respect the client's right for self-governance? We are legally and morally encouraged to and required to take care. Basically, after all, we really need to lean into the side of life. But at the same time, there will be times that all of us are going to work with individuals who do not want to be saved, do not want to continue in this life. So how do we preserve their autonomy as we work with them? Beneficence, responsibility to act in the way that we provide the greatest benefit for the client, not just benefit for the client, but the greatest benefit. And as we talk a little bit about this, think about some of the suicidal clients that you have had. What was the greatest benefit for the client? To work with you in outpatient or to go and admit themselves to the hospital? So think about the greatest benefit. Fidelity, faithfulness to the best interest of the client. Those two, beneficence and fidelity, go hand in hand. Non-maleficence, responsibility to use a non-coercive approach. How many times have you seen or heard or noticed that a client has been forced to go to a hospital? Is that the best benefit, the greatest benefit for the client? Can that client manage their suicidal ideation at home with an outpatient therapist support? Think about our clients have families, they have jobs that they need to maintain. So where is the greatest benefit for the client? Veracity, duty to truth and honesty. That actually applies to us as therapists. Sometimes we might be underestimating or overestimating the suicidal ideation that we see in a client. So that's where it talks about duty to truth and honesty. Are we being completely truthful and honest in recording patients' responses, in recording their symptoms, in recording the severity of those symptoms? That is important because that also will depend or will determine the next level of care for that particular patient. Justice, commitment to the act of fair treatment without any prejudice. Think about if you are working with an elderly person who might be at the end of life naturally, might be an 85 or 95 years old man who is in quite a bit of pain. Does that patient need treatment? Somebody might think, well, he's almost at the end of his life. We cannot necessarily practice any prejudice when it comes to being committed to the best interest of the client and providing fair treatment to all of them. Privacy, protection of clients' personal information. We'll talk a little bit about this today. And the last one is integrity, honorable conduct within the profession. All of us. Even though we don't take an oath like doctors do, but all of us have committed to being, to really doing the best that we can within the guidelines of our professions. Really, that honorable conduct is something that we are all bound to, and we have a responsibility to our clients to conduct ourselves honorably within our profession's guidelines. All right. Okay. As we assess clients, there are two common responses. Well, there are three really, but the most common ones are better safe than sorry approach, where suicide risk is overestimated. We overestimate it because we are afraid of litigations. We're afraid of any legal actions that might be coming to us. We're also afraid that we are going to lose a life. Really, most of the time, suicidal ideation is overestimated. A few times, due to lack of training, we also have the dismissive approach, where the risk is not necessarily assessed in an adequate way. And that could be something, if you have new therapists who are working with suicidal clients and you are noticing either one of them, better safe than sorry, or really an underestimation of the risk suicide, maybe some training needs to happen. But regardless of where your therapists are or where you are, think about, why are we overestimating? Why are we underestimating? What are we concerned about? Are we doing this to protect ourselves, or are we doing this to give the client the very best benefits of treatment? We've got a lot of clients who are struggling with suicidal ideation, but not all of them are going to die by suicide. And can we predict it? Can we really predict which one, if we have 5 suicidal clients, which one will die by suicide? This is very difficult. There are a lot of items that can go in there, but we cannot necessarily predict who is going to die by suicide. We've got clients who are engaging in significant self-harming behaviors. We've got clients who are driving recklessly. But are they always, are they attention seeking? Are they being truly suicidal and they might have a plan? We don't know. It's very difficult having that relationship with the therapist and with the client, for the therapist to truly understand, is this patient at high risk for suicide, can be helpful. Sometimes an attempt that our patients that you are seeing in our clients and our patient can be simply a cry for help. It's a high risk strategy for them to alter their painful situation. But do they want to die or not? We don't know that. It is very predictive. So it can be different items can be there. Thus, the importance of the assessment and really working with suicidal patients to understand where they are. Here are a couple of ethical situations that I'd like to see if we can collaborate a little bit on this one. You believe your clients needs to be checked in the hospital for severe suicidal ideation. Client does not want to go and states that if you call the police and they take her to the hospital, that would be traumatic for her. By the way, this is a real case, you guys. And she will kill herself there. You have called the police 4 different times on this client and they have not pink sheeted her. You call them again and they say, we already know her, she won't do it, and we won't force her to go to the hospital. What are some ethical considerations in here? What would you do if you were to be the therapist in this case? Can you force a client to go to the hospital? Safety plan with, ask why she wants to die, arrange for the MCOT outreach. Yep, these are good alternatives. These are, I mean, not alternatives, but these are good responses. Excellent. This patient actually did not go to the hospital. She's still alive. And the police did not pink sheet her because they had pink sheeted her before so many times. They considered her as attention seeking. She is in quite a bit of emotional distress, but because she has not followed through with her threats of completing suicide, the police simply said, We cannot force her. We know her. She is managing her symptoms with her outpatient therapist. Get her connected to family or friends. Absolutely. See if she has a friend or family member who can pick her up and be with her or take her to the ER. She did not want to go to the ER. So good thing for her is that she is still alive and she is managing her symptoms. But we cannot force people sometimes when they don't really want to go. Yes, there are cases a lot of cases where the police officer, law enforcement are going to pink sheet the person. You can also, as therapists, we can also blue sheet the people, blue sheet some of our clients for them to go. There are court commitment that can be, especially when you have a client in the hospital, there are court commitment that can allow us to treat an unwilling patient or somebody who does not want to stay at the hospital when we think that they are risk to themselves or to others. But in outpatient settings, a lot of times you are going to deal with individuals who are crying for help, but they cannot be forced to go to a hospital. Here is another one. Your client is discharging from an acute hospitalization. They have not given you permission to disclose any information about their suicidal ideation. They did give permission for the therapist to do the safety planning with a family member. You know, as a therapist, that there are items at home that the client can potentially use to harm themselves. What are you going to do? How can you maintain confidentiality and privacy of the patient while you are doing the safety planning with a family member? This is also a real case, guys. Most of both cases are real. In this case, actually, what I did, it happened to me here at the hospital. The patient did not give me permission, and he had told me what he had at home. So, as I did the general safety planning, basically the item that he had planned to take his life with was computer cords. The wife did not know that he had attempted with computer cords before. So when we did the safety planning, she said, I have cleaned the house. We don't have any curtains or anything else that he might hurt himself with. There are no sharps. There is no substances. There is no alcohol. There is no guns. Think about something else. I said, is there anything else that he can use to strangle himself? And as we just did this question and answering, the wife said, wait a minute, we've got computers and they have cords. So simply by directing their attention to other things, asking them more questions, you could do that safety planning without really giving away the information of the client. So it's not me who is revealing that information, is simply asking the wife different questions so she could actually think of different situations or different items that her husband could use to self-harm. Yes, sometimes when a general safety plan, that will be it, and you can also throw there the item, the name of the item when you do the general safety planning. Have you thought of any sharps, alcohol, substances, guns, cords, curtains, anything like this that he might use? So you are still not giving away the personal information, but you are directing the loved one's attention to what needed to be directed to. Okay, here is another one. A patient is admitted at a psychiatric hospital for suicidal ideation. Close to the time of discharge, the client increases suicidal ideation. His therapist meets with the client, and the client reported, I want to kill myself so I don't hurt people. I see people, and all I think about is how I can hurt them. The therapist meets for a while with the patient and leaves the session feeling good about giving the patient some more hope. Then the therapist's thinking goes to, what if the client I just saved his life goes out and hurts one of my family members? This is also another real case. Can you see the ethical dilemma in here? As a therapist, I'm going to always lean toward protecting and preserving life. But this particular client didn't want to live. He came to us as, it's better for me to die than me hurting other people. So he was quite aware of that. And at the same time, as he's ready for discharge, he recognizes, if I go out, I'm going to hurt other people. I don't want to do that. So it's best for me to die. Therapist goes in there. And I remember the therapist, when came out of that session with the client, it was difficult for the therapist to deal with that situation. I saved somebody, but what if he is now going to hurt one of my family members? How am I going to feel about saving somebody's life who is going to hurt my family member? So, I don't know. Duty to protect, we've got this. Basically, as practitioners, we are legally bound and expected to actively prevent the suicide, of a client who is suicidal. But there are so many ethical situations and thoughts that are going in there. Is that ethical to save somebody's life when they want to die? With We have a lot of people who have a necklace who says do not resuscitate, but we don't have that for suicidal clients. I know, actually, I have I have a family member who, at the end of his life, he was in pain, he had cancer, and at the end of his life, he wanted to die by a lethal injection. However, the state that he lived in did not allow for that. So he had to, basically, he died naturally of cancer. But at that particular time, it was, instead of me going through all this pain with cancer, can I just make it easy for myself and die? It was not allowed. He had to go through some psychological testing to actually make sure that he was mentally capable to make decisions. That testing took a very long time to be approved. The patient died due to cancer. But think about this also. If you have a client who is at the end of their life and they do not want to go through the pain of cancer, do we let them die, or do we save their life? So something to think about as you are working with suicidal patients. Now, when it comes to, let's talk a little bit about how can we apply those ethical principles that we talked about. And I'm going to take this into three main areas of our work with suicidal clients: assessment, treatment, and safety planning. So let's start with assessment. Are we doing thorough assessments? When clients come to us with suicidal ideation, they are in significant distress. I read one of the comments in our chat that sometimes when they come to us, they don't even tell us exactly how suicidal they are. They don't want to reveal the plan that they have. They are quite reluctant to disclose symptoms for two different reasons. I think might be more reasons, but judgment from the therapist. Also, what will happen next? What if my therapist is going to order me to go to a hospital, and I cannot afford right now? I cannot afford payment for the hospital stay. I cannot afford not going to work for several days. And I have young children at home. Who is going to take care of them? A lot of us have family members or good neighbors who can take care of the children, but not everybody has that luxury. So as clients are coming to our offices, simply be aware that they are not always going to disclose honestly their symptoms there and their severity. A lot of times there are a lot of misperceptions, and especially if you are working with people from different cultures who might not be so well educated into basically what is depression, what it means to struggle with depressions, what are the common treatments for depression. When you are working with individuals from different culture, it might be even more difficult for them to disclose to you symptoms, honestly, symptoms of their symptoms and severity of their suicidal ideation. Some things that we need to be aware of when we do the assessment. Have we talked about, or have we done an assessment of the risk factors and warning signs? Sometimes you might not know all the risk factors, but the more the more you know the patient, the client, the more you can recognize those factors. Baselining is going to change. The more we know, the better we can make the decision, especially for the new therapists who are still in training. They might not know exactly what to do next. So the more we categorize this risk, if the client is here, this is what we do. That decision tree making, it can help the therapists who are dealing with this particular population. And sometimes, especially for the new therapist, dealing with the suicidal clients, especially if it is the first or the second client, might be a little bit traumatic for them as well. So some education needs to be done when it comes to assessment, treatment, and safety planning. Do we need sometimes consultation from another colleague or from another supervisor? This way, we ensure the highest standard of care. I might be in dilemma about what is the next level of care. If I consult with somebody, they can help me understand better the red flags. During assessment, we also need to understand and also help the client understand what will be the duration, the frequency, and the intensity of suicidal ideation. How can you understand this when the client is not going to reveal that information to you? Again, the better the therapeutic relationship with your client, the better you are going, or the more correct information, accurate information you are going to get from the client. What else can we assess? History of suicidal behaviors. What is their intent and planning? And do they have any means? Do they have any history of suicide attempts in the past? What do we need to do? Ethical documentation. What is the risk level? Remember, we talked about some of the principles, the ethical principles, and documentation was one of them. Document ethically, document honestly. The risk level, the actions taken, and the safety planning. The actions taken are very important as well, because if a patient does not follow your guidelines, documentation is going to be helpful to you if you are going to find yourself in a lawsuit. I actually heard recently about a family who sued a hospital because discharge planning or safety planning was not completed with the patient when the patient went home, and she killed herself when she went home. So we'll talk a little bit about safety planning as well. But as you are going to do the assessment, as you are going to participate in assessment, think about, are we respecting the client's autonomy? Respect for the person. Are we treating the client with integrity? Are we having in mind the best benefit for the client? And are we making suggestions for the greatest benefits for the client's treatment? If we have those things, if we keep those things in mind, most likely we'll be able to do some great assessment. An important part of the assessment will be protective factors. We usually focus on the red flags, but protective factors are very important. I'm not quite sure what assessment you are using in your practice when it comes to identifying the risk for suicidal ideation. We use the Columbia in here, and with Columbia we actually have added the protective factors. They are important because when we identify the protective factors, we remind the clients of their own strengths. We identify support for the clients. Protective factors can also help us understand, along with you are doing assessment, but they really are going to help us understand what is the right level of care. If there is no support that this patient has, maybe the right level of care is the hospitalization rather than outpatient support. So combining both the red flags, the risk, and the protective factors can be very important. And also, as we are talking about the risk and protective factors, you could also do some education. It increases suicide awareness. The more aware clients are about their suicidal ideation, about how to manage those symptoms, how to manage depression, the less likely they are to complete suicide. So the assessment is one of our most important aspect of working with suicidal patients, because it's going to really set the stage for what is going to happen next. Let's say one of your suicidal clients in outpatient agreed by you, by your encouragement, or by police, doesn't matter, but agreed to come to the hospital. As soon as the client comes to the hospital, they are going to sign the informed consent. Informed consent is more than just a piece of paper that the client signs for us to justify, okay, we now can give you medication and we can provide treatment for you. That informed consent is something that is a very informative time, information giving, and education for the client. Some of the things that you could do during the informed consent: help the client, educate the client, help the client understand how can the client maximize the benefits of treatment. So here are the risks and here are the treatments, and help them understand why the hospitalization can actually maximize their treatment. Um, we've got to inform the patient and a thorough information, and we also need to check with the patient if they understood, because I can talk for an hour and the patient had no clue what I talked about. So always check with for understanding. Confirm with the patient if the information that you have delivered to the patient was totally understood by them. But some of the things that the patients have the right to be informed through the informed consent. Um, how is the suicide risk going to be managed at the hospital? It might be through medication, through group therapy, through individual therapy, through family therapy, but they need to know. They need to know what assessment they are going to be participating in. They need to be educated on what clinical procedures will be used to treat their condition. They need an explanation of best practices. And what I mean by that is the patient can understand this is what you gain from outpatient therapy, and this is what you gain from a hospitalization. So, what would be the best practice for your situation with the symptoms at this point is hospitalization. They also need to understand clinical decision making. Um, what I mean by clinical decision making is that for some of you who work in hospitals, you might also have encountered quite a bit patients who do not want to comply with treatment. Who is in charge of the patient at that time? Who makes the decision? Does the patient make the decision or does the doctor make the decision? And again, think about the values or the principles, ethical principles that we talked about. There are times that the patient will make the decision, and there are times that the doctor will make the decision. But the patient needs to know right away how is decision making going to be done. They will need to be informed about this is the against medical advice process. They will need to be informed about court ordered process. How do we keep a client in the how do we treat a client when the client is unwilling to participate in treatment? So all of those are very important because the more information the clients have, the better decisions they are going to make. They need to know about the potential length of stay. They need to know about who is their doctor, who is their therapist, and where can they take their concerns or their questions. Patients need to know about confidentiality. How are we going to keep confidentiality? How are we going to treat their information? Again, the more they know, the better information they are going to give us about their condition. They also need to know about safety planning at time of discharge. They need to know what happens if they have a medical emergency need. They need to know about what's going to happen, where are we going to refer them at time of discharge, and other items as well. But the more you provide, the more information you provide, the better it is for the patient, the easier it is for the patient to provide information back to us. And this information giving should be transparent and collaborative. This way, we take in consideration and we respect patients' autonomy, respecting the person and their integrity, beneficence, privacy, and veracity. Again, every decision that we are going to make, every assessment that we are going to make, every interaction that we are going to have with that patient needs to be done based on those particular ethical principles. Okay, Safety planning. Wow, our time is going fast. Safety planning. Safety planning is an ethical obligation. I don't think I can, I don't think that I can say it differently, but to me, especially hearing also about this example that I told you a little bit earlier, a family that sued a hospital, not our hospital, by the way, it's a different hospital in the community, but safety planning was not done. The patient was still suicidal, patient was discharged at home, some safety planning, some very little, but a patient was sent home with no referrals. No, I misspoke. Patient was sent with no appointments. Some referrals were given, but no appointments. And safety planning when it comes to medications at home, lethal weapons, or anything else was not provided. Unfortunately, the patient died. So patient, oh, I'm sorry about this, you guys. I don't know what happened. We just got disconnected. We were in safety planning. So let's talk a little bit about this. It's an ethical obligation because we owe it to our clients. Their safety is in our hands. It needs to be comprehensive. We've got to cover a lot of items, a lot of situations that patients or clients might be encountered so they could be safe. Best to do with somebody else, with the patient and with somebody else, but not just with the patient. The patient needs the support from a support person. It can be a family member, it can be a neighbor, it can be a friend, it can be somebody else. The more we focus on safety planning, the more awareness we can give to the clients about how, and the family members, about how to prevent suicide. Not only that, but when we talk about safety planning, we also remove this harmful language that is related to our patient's suicidal thoughts and behaviors. You also take care of some of the misconceptions or misunderstandings that the clients can have. If we are going to focus on safety planning and we do a transparent with the patient and with their family member or support person, we really take care of patients' autonomy because they are going to choose if they are going to go, for example, in an IOP level of care or in outpatient. That's very important, respecting their autonomy, respecting their dignity, doing the best for them and protecting their confidential information, protecting patients from harm. At the end of the day, regardless of our personal beliefs or our personal values, we are expected to save a life. We are legally expected to prevent any client from any suicidal ideation. Okay, let's see. Let's see. Well, here is a case scenario, you guys. Mrs. White is a 25-year-old woman who was referred to the therapist by her obstetrician. She reports increased symptoms of depression and anxiety. She is 4 months pregnant with her second child. She and her partner are the parents of a 2-year-old daughter. During her first meeting with the therapist, Mrs. White reports that she has a long history of depression and stopped her medication due to fear of harming her baby. She struggles with severe postpartum and after her first pregnancy and was hospitalized for a suicide attempt. 2 weeks after starting therapy, Miss White reports poor appetite, insomnia, intrusive thoughts of hurting her 2-year-old daughter. She reports feeling ashamed of having these thoughts and states that she will never hurt her daughter. She also reported that there have been days that she let her daughter do whatever she wanted to, as Mrs. White could not get out of bed. She reports that she does not want to take any medication. And in the following therapy session, she reported that she has, she reported that she has not been sleeping because she fears that her husband or her partner will kill her and the baby. She said, "I'd rather do it myself than let him hurt us." She was observed to be agitated and hypervigilant and with rapid speech and increased psychomotor activity. If she was your client in outpatient, how would you help this client with her suicidal ideation, what would you do? There are so many things in this particular scenario, actually, but what would you do? What would be your response on this one? What are some possible? Notify domestic violence? Absolutely. Yes, you've got domestic violence from her partner. Sometimes the risk of being off antidepressant is worse than the risk of being on them. Totally agree with you. Because she's off medications, she's actually not able to take care of herself, her pregnancy, and her 2-year-old daughter. Absolutely, yes. Let's see, what other things do we have in here? PDD assessment. Yes, you could do that as well. Absolutely. Yes, this particular, the suicide is an escape from husband killing her. It could be quite possible. Talk to colleagues to see what resources are available. Childcare, some helper agencies, absolutely. Yes, these are absolutely great responses and appropriate responses to do or to take to actually take care of this particular case. Inform the clients about the benefits of antidepressants used in pregnancy, very important. Inform the client of risk of not being in treatment and how is that going to impact her and her children. Understand the nature, help her understand the nature and severity of her illness. Understand or help her understand the consequences of untreated depression and the risk for suicide. Possibility of the partner violence. It's not necessarily a possibility. We can see that it is really happening there, but sometimes it can be a possibility depending on what the client might be. You might have a client in psychosis, so you don't really know. So that's why it is written as a possibility. Encourage the client to sign a release for the purpose of engaging the support system if she wants to. And support system can be a mother, a father, a friend. Doesn't have to be the partner. Complete a suicide risk assessment. Any of those responses could be appropriate. What are some of the risk factors in this particular case? We've got worsening symptoms, medication non-compliance. We've got emerging psychosis, having pre-existing mental health illnesses. She also had a suicide prior attempt. But we've got protective factors as well. She wants to be a good mother and she wants to participate in therapy. Okay, let's see. I've got only 2 minutes, but at the end of this, what can we do better? Of course, there is the need for understanding those ethical principles so we can apply those principles in our work with suicidal clients, and also doing more education, more training for our new therapists who might not be knowing exactly how to handle the suicidal clients. Also, educating the clients and their families, talking openly about the impact of depression, the impact of anxiety, the impact of suicidal ideation in their health and in their relationships. So the more education we provide, the more information we give to the clients, and the more we follow the more we stay true to our ethical principles, the better it's going to be for us to build that relationship with the client, to help them and to understand exactly what their baseline is. All right. Well, you guys, our time went very fast. An hour is not enough time to really tackle this topic. I wish you all the best in your work with your clients, and I hope that you can remember those ethical principles in your work with them. Any last questions that I might take? Yes, we are going to do this presentation as 05 suicide and 05 points ethics.
All right. Um, Just once more, if you have a question that maybe I overlooked, please unmute. Go ahead and ask the question now if you'd like. Otherwise, we'll be logging off here in a few seconds.
I just had a question about collecting collateral information and the ethics behind that. Like, if someone is maybe a family member brought them to the hospital or a friend brought them to the hospital and, the patient's not quite forthwith what the circumstances behind them coming to the hospital. I guess the question is the ethics behind collecting collateral information about what happened that made that had the patient brought to the hospital.
That is a great question. We have so many of those cases. If how do we handle that in here is we have to respect the patient's right. If the patient does not give us permission to talk to the family members, we have not. However, there have been times that family members know that the patient is here and they call us. And the ethics behind that is we can collect information from them because they already know that the client is in here and they are telling us. But we cannot provide any information back to them. So you can listen to them, but you cannot provide information back.
Okay. That sounds good. And I guess I'm a crisis worker in the emergency department. So I guess yeah. I never really asked my colleagues that question, and that now makes more sense.
Yes, and we have had also family members who assume that their loved one is in here. They don't know for sure, and they probably have called 2 or 3 hospitals thinking that one of them will be the right one. What I've done in that case, Ben, is that I've told them hypothetically, if we are going to treat basically as we treat one of our patients, this is what we offer. I tell them about this is our programming, this is what the patient is going to receive, this is how we're going to work with them. So I'm simply giving them detailed information about our program, but not necessarily anything pertaining to their loved one, which if the loved one is a patient here, they're going to get the same programming, but nothing, I cannot provide any information about their family member.
Okay. Thank you.
You are welcome.
And Vilsa, it looks like a follow-up to that question. Someone in the chat asked, what if it's a minor? Do you treat the scenario differently if it's a minor?
Yes, absolutely. With the minor, you also talk to the guardians without any release of information. For the minor, the parents or the guardians it becomes basically you have a unit now. So for the minors, you do not need a release of information form. The only thing with the minors, and I'm not quite sure, you need to check on it. I need to check for myself, but if they are either 14 or 16, I'm not quite sure. It's not quite related to the suicidal ideation, but if they have sexually transmitted diseases and substance abuse issues, the minor has to consent for the parent to know. But I'm not quite sure which one is the right age, the 14 or 16. I've got to do some checking. You probably are right, 14. And I remember I worked with a client like this who had sexually transmitted diseases. The nurses had done their education with the client. I was supposed to do the education with the parent. And how I handled that, I said to the mom, hey, I just need to do some education about some STDs. Mom got it. And she asked me, does that mean that my daughter has an STD? And I said, I cannot tell you, I cannot provide any information, but I'm going to just give you some education. She got it. She got it. And when you are coming as, I need to do this, I need to provide you with this education, family members have dealt with their loved ones and they are aware of their issues. So they will put the 2 and 2 together and they will get it. So you are still giving the information without disclosing any information. That I don't know. 14, yes, that's why I said I need to check. But either 14 or 16, I know that our director of medical records will always say, if you have a patient who is with STDs or substance abuse, we've got to get consent. I just cannot remember the exact time now. And just because they don't consent to sex, that doesn't mean that they are not having sex. They can have sex with an adult and the parents do not know, so you never know.
Great. Any other questions before we end today?
Thanks for being here, you guys.
And thank you for your time, Vilsa.
Thank you, Joseph.
All right, everyone, enjoy the rest of your afternoon. We'll see you next month.
Okay, bye-bye.